This is a treatment introduction video for Liam. In this procedure, notice how I chose depth and position carefully, and it's much more sculptural than it would be with kind of stage injectors. So when I say sculptural, I mean I'm looking at tiny details, making small adjustments on the path towards a better result. I don't just place 6 or 7 injection points like I do for all my patients in the same places. I do it really bespoke for the individual, and it does change as I go through the process, which I think is a normal part of honing a really good treatment. Little adjustments, lots of places in response to what you see. In this patient, we treated the lateral lid cheek junction, which was a key part of getting a good aesthetic result, a very small amount in the tear trough. We also did a non-surgical rhinoplasty so that he had a straighter nose from the profile. In fact, it was perfectly straight by the end. And we also did a chin and slight jawline augmentation, although we didn't do the lateral jaw for reasons that are explained in the procedure. Okay, so it's important to work in a logical fashion from top to bottom, from lateral to medial is what I usually follow. You can start out by creating a plan, but remember this is actually an artistic endeavor, so your plan will change if you're paying attention according to how each injection actually affects the result you want. Most important thing when you're injecting the cheek and the midface is to be aware of your defining points. So the defining points are what makes a face a face. And if you don't know what those are, then you will lose details. So in terms of a man's face, it's at this angle of the zygoma here that is key. And you can actually feel this, so feel for the anterior part of the zygoma and then the lateral part of the zygoma. And when those two surfaces meet is the defining point, it's right here. Now you can also mark that out. You'll see people mark it out various ways, like from the tail of the eyebrow to the oral commissure, from the alar base to the root of the helix. And these are useful things to kind of double check, but I still have never found anything as good as actually feeling for the shape of the bone. But you will see these types of lines drawn on patients, and they are helpful. But if you don't know where the actual defining point is, you will end up getting it wrong because curvature changes how you draw things on. So this happens to be pretty close to where I thought it would be. So that's a key point on the face. That will tell me what a cheek is versus some other ill-defined structure. The next thing is to be aware of in which direction you want to create curvature. If you're trying to create an angle on a man's face, we need to make sure that we are not firstly feminizing him by making it too high, a cheek that flows upwards and compresses the lower lateral lid, creating a more almond-shaped eye is a bit more feminine. And the other thing would be lateral projection. Men do not tend to have lateral projection. It's definition, and the cheek is relatively small compared with other features. We do not want to create big, full, round cheeks. We want to create an athletic appearance, which means you see definition and detail. You see the contour, but you're not seeing a round, large fat pad on top of it. So the term I would normally use to describe this to a patient is to focus the cheek. I'm not enlarging the cheek. And this is the focal point of the cheek right here. So that's probably going to be my first injection. I don't normally do all these drawings on faces, but I know it helps new injectors. If I was to continue this along, I would follow that same path because this is the path of the zygoma. And in terms of projecting anterior cheek, I would also be thinking about where this line is crossing to project anteriorly. Now, the actual thing that I'm looking at when I'm injecting is not the markings. This is something that happens as you become more and more proficient. You stop looking at the lines and you start to look at the reflections of the cheek surface in the light, because then I can see actual shape, three-dimensional shape and surface textures, which are really what I'm trying to control for. I'm not trying to create a line. I'm trying to create a continuous arc which is defined along the line, and I can see that much better with the lights reflecting. For example, I can see a light reflex here and then the dip off here, which is what we're actually going to treat later on. So I always start with cheek first though. So once again, that's exactly where we thought we'd be. And I'll do that on either side. A helpful way to think about this is also to think about the greatest curvature. So if I follow the shape around here, I'd say the greatest curvature is probably maybe around here. And really, I can feel the bone underneath is here, so I'm trying to move the curve outwards by about 7 millimeters to create definition in the right spot. So as I prepare to inject the cheek, I usually just reflect a little bit on the anatomy, what vessels might be nearby. It's actually a relatively safe place to inject. Very rare to get a blood vessel on the periosteum. So it's one of those areas I think is probably least likely to cause a vascular occlusion, but I still like to think about those vessels. There's the zygomatic facial artery that sometimes is higher up, and the transverse facial artery that's usually about 17 millimeters, according to average position, below the zygoma. So both of those are not near where I'm going to inject. I'm going to do a deep injection on the periosteum. I'm aiming for the periosteum right above the angle of the zygoma, which means I'm not going to go through this dot that I've marked, but I'm aiming for a point underneath. So a little injection coming. You can actually feel when you touch the bone, you can get an idea for the shape of it. Make sure that you're on an apex. Aspirate, although, as I said, super unlikely to be near a vessel. And then so I can see this shape is exactly where I wanted to. I'm happy with that result. Do the same on the other side. I'm on the lateral side of the zygoma because, remember I said how I wanted to shift the greatest curvature laterally. Okay, so now I'm injecting lateral lid cheek junction. Lateral lid cheek junction, you can test how well it's going to affect by putting a little bit of pressure underneath it, and if you see the skin pop out and it looks clearer, you're likely to get that result in the end. This type of patient is ideal because he has relatively thick skin. He's going to hide product quite well, but I also want to make sure that it stays deep. One of the downsides of any area around here is if the fillet becomes more superficial, it's easier to see. So the injection technique I use for this is to enter with the bevel facing downwards, touch the periosteum underneath the greatest indentation that I can see, and then slowly inject so that it's staying underneath the fatty layer, underneath the orbicularis oculi. The fat pad we're actually injecting is the SUF, the suborbicularis oculi fat pad, but I actually want to be underneath the SUF if I can get that deep. So that means downward facing bevel on the periosteum. That's the point that I'm aiming to lift up. Very easy to aspirate with this device, 0.05. I'm just going to change position very slightly. And then a little shape. That is great. That has brought it together nicely, but there's still, I would say, a general sense of this lateral orbital fat pad being ever so slightly depleted when you compare it to the cheek. So I'm now going to, having corrected the lateral lid cheek junction, just move slightly more superiorly and give a little bit of continuation to this, what looks like the shape of the zygoma with the fat pad above it. We just need to elevate that slightly as well. I hope you can see this on the camera, that often tiredness as a complaint is caused by a shadow here, as well as a shadow underneath the eye, but it's this downward sense of shadow at the lateral part of the eye that is to do with depleting lateral orbital fat pad. And we can shift this in the right direction quite easily with a small amount of product. So same principle, deep on the periosteum, underneath orbicularis oculi, with the bevel down. Change positions there because I could see it lifted well. I just wanted to connect the next bit. And then you can see that little bit of product, which I will now mold in to create the shape that I want once I've stopped this little bleed. Great. Now I hope you can see that already. The cheek is now much more shaped in. It no longer is an island. Cheeks usually become a little bit isolated like an island. The contours, you can basically see the orbicularis oculi ligament on top. You see the zygomatic ligament crossing it. You sometimes see the junction here where the masteric ligament runs up the line of ligaments down the side of the face. And that's now become all one shape. Blended in. Harmonizing is a key part of looking youthful. Blurring boundaries, but having definition in the right spot. How are you feeling? You okay?
Yeah, good, thank you.
Okay, so now we're just repeating the same on the other side. The same process, identifying where the deepest aspect of the shadow is, respecting the contour you're trying to create with the cheek. And I'm going to find, there's a little vein here which I need to miss. I think it's a vein, very faint. Bevel of the needle down. Choose my periosteal touch point, and then through muscle, fat pad, touch periosteum, aspirate. See that kind of projected a little bit lateral to where I wanted, so I'm going to stop, change angle, and go a little bit more medial for the next bit. It's really important to watch the surface of the skin very closely as you're injecting to validate that you're causing the change that you want. So that little bleed that started as I pulled the needle out, that I would say that's moderate, but it's enough that I'm going to not do anything now for a while to hold it. A bruise around the corner of your patient's eye, it often means very little to clinicians until they hear the stories and the way that it affects the patient afterwards. But they're often even an amazing treatment where you get a bruise. It removes a lot of the benefit. So I always try extra hard to reduce bruising, and now's my chance. So you don't tend to stop bleeding very easily if it's a wet alcohol wipe. So you need a dry cotton bud, and that looks like it's stopped. Despite the size of that, when it first came out, I don't know if you caught it on camera, but I can now see nothing, so hopefully we'll get no sign of bruising at all. Still a slight bleed, so I'm going to hold it another 30 seconds. The rule of thumb is hold it until it feels like the rest of your life is going to be holding it. So that depends on how patient you are, but I find about 30 seconds in, it feels like forever. And usually for a bigger one, it's a minute that you need to hold. This probably isn't a minute. I think 30 seconds will be enough. But I just want to do everything I can to make and to lower the chance of bruising. And even if you fail, your patient will still appreciate the effort. I'm going to do the same as I did on the other side, try and link up this contour here and improve the lateral lid cheek junction. That's where I'm going to be aiming for, but I'm going to be going underneath orbicularis oculi, underneath that little vein that we can see. touching periosteum now. Watching the surface of the skin. Once again, slightly lateral, so I'm going to slide more in medial. Now going for this tiny indentation. Unlikely you'll be able to see it, but it's as if this little cotton bud had been resting here. So I just want to plump that out very slightly. I actually don't want to remove this. It's a natural contour of the skin. I'm just blending it in so that we have less of a shadow. So because I got such great light here and I can see little light reflexes, you see these catch light points and little shadows in between. Those are really what we're trying to blend in. So around here, I think of it a little bit like visual clutter. Creates just a slightly cluttered appearance instead of a harmonious appearance with this mixture of highlights and lowlights. So this is one of those key areas just here that although it's very tiny and you wouldn't notice it, no one in a million years would notice this and feel distracted by it, but it informs an overall sense of the face, either the age or whether someone's tired or not, although it's often not correlated, like we said. So it's worth me chasing that tiny little indentation here because that will declutter around the eye. So I'm going to just try and improve it a little bit more with another injection just here. So what I'm picturing here is now angling my needle down to catch the curvature of the zygomatic bone. Right, it's not really the tear trough, we're lateral to that, but I'm right on that outward curve to get this to project outwards. Bevel is down again because I want this product to stay deep. I would never understand why people say you can't hold the needle still when you aspirate. This needle is as still as, the tip is as still as it could be. Of course, this ring really does help. So similar principle here. This cheek is different to that cheek. We have an ever so slight difference in the fullness of this fat pad. And I think it's a little bit more challenging this side. I'm going to try one little injection just here, just to try and get a little bit of elevation to blend in a fullness and an emptiness that are right next to each other. Another new needle has been put on. So to my eye, the tear trough already looks better. I think this lateral part of the eye, the lateral lid cheek junction, is often more of an issue visually than you'd think. When I look at the tear trough, it just seems like a much easier problem, much smaller problem, let's say. I don't want to chase this too much because this is the area that causes more of the issue. So I might do a very light touch, little bit of projection, but I'm going to keep it like 0.1 mils, maybe 0.15 on each side. So before doing the tear trough, you can use cannula by all means. The problem with cannula is you always end up in a more superficial layer. And the way that I've come to understand tear trough and the way the filler presents is that if you have dermis, muscle, and then the retroorbicular oculi fat pad, and then the periosteum, it's filler that gets the top half of that fat pad that you start to see, particularly if it gets through the muscle. So what I imagine happening is if it's in the mid layer, there's a lot more movement around the eye, and basically it starts to be, it's a bit like if you're a boat on the ocean, the waves at the top can be very noticeable, whereas if you're a submarine, you don't notice it. So I like to place periosteal level injections for tear trough because I think it's a better long-term result. The downside is a little bit higher chance of bruising, and if your anatomy is not good, there are some other risks that are super rare I've never had in terms of injecting filler, which actually also happens with cannula anyway, but into the globe, into the orbit, so behind the orbital membrane. So the easy way to avoid that is just to know the shape and contour of the bone so that you can feel you're on an anterior facing surface rather than kind of slipping off down a ledge, which would be leading you into the eye, obviously. Now we can make that super easy, first of all, just by feeling before you start. If you take a cotton bud, even a smaller one like this, and just feel the shape of the bone, just feel where the edge is, you'll sense where it's about to slip off. It's very close to where the shadow is, but it's definitely not underneath the shadow. So if I stay on this level, then I'm not going to be able to get filler to slide off into that ledge. So have a feel of that first, and you should be very reassured that directly underneath where we want to treat, there is bone all the way along. Once you understand that, the only way you can get it wrong is by entering in such a way as your entry point does not reflect where the needle meets the bone. So if you entered like that, you could easily go in the wrong direction. So we're just going to enter in such a way as I'll either be exactly where I expect or away from the eye rather than closer than I think. This is an injection where you want to be nice and stable, stabilize your hip against the bed, stabilize the patient's hand with your left hand, and then stabilize your hand on top of it. And we're just going to go gently onto periosteum. So aspirating on periosteum again with negative pressure. Now I'm going to go for a more medial point. So aspirating there was a little wobbly, so now I'm going to stabilize with negative pressure, check that it's negative, and inject again. This line here caused by the zygomatic ligament, where it branches to orbicularis oculi, there's often a point right where those 2 points meet that looks most like where you draw a tear on a typically a clown has that kind of that little tear just here. So this is an area that I like to do my best to connect. So I want the cheek to connect smoothly with the nose with no interruption. I can see with the light reflection there's a little interruption here. So this is not really a tear trough treatment. It's kind of like upper cheek, about as close to the tear trough as you can get. But I think it's worth doing to try and get that connection. total volume I've used is less than 0.1. It's a very small, light treatment, but it's making a difference. Okay, so we're now just doing the same on the other side. I will also use a slightly stiffer product here on the midline, and then, because it's basically upper cheek, and then work up as we did before with Volbella in the medial cheek. Bevel down. Remember, just get an idea for where the periosteum is. So I was just thinking, this is just one of many steps that I will do to limit risk. So many injectors are terrified of doing non-surgical rhinoplasty because it holds pole position for our worst fear, which is blindness. But I always think those injectors are probably the best people to do these injections. I don't really want the injectors who think, well, complications happen. I want the ones who are terrified of it, because what happens is you develop a protocol that makes your patients really safe. This procedure would be done and dusted in many clinics already. They would have just bolused it in, sent him on his way. Literally, you can do it in a minute. But all these extra steps, they bring peace of mind to me and the patient. And I think it's possible to inject in such a way as you would have virtually zero chance. I would say it's effectively is zero chance causing blindness. It all involves small amounts validating that you haven't caused a problem in between each tiny step. Should leave you sleeping comfortably at night, not worrying about the thing while also getting your procedures done. Okay, so to do a nose, I usually think last before I inject is just getting the aesthetic goal clear in my mind. When I elevate the tissue from one side, I can see very clearly that his nose is nearly perfectly straight with quite a small elevation, but it also helps me guide where that elevation needs to be. It's a little bit, if I look at the curve of his nose, it drops off a little bit, and I know that that drop off is where if I elevate that, it won't change the shape of his nose too much without getting it straight. So it's a tiny adjustment as the curve, the rate of decline or the rate of the curvature of the nose picks up, that will give me the biggest bang for my buck. So that means the smallest amount of product, the lowest risk, the smallest overall change while still getting a straight nose. That's really what I'm after. If I was to start higher up his nose, I could still get it straight, but I end up putting twice as much in. Low volume is safe, it's cheaper, it's less likely to cause a complication, and you get a more natural looking result as well. So that is what I'm doing now. Then I will flick back to thinking about complications, which is where are these vessels likely to be? I've already seen there's one off the midline, which is where it's supposed to be. I couldn't find anything on the periosteum where I was about to inject, but I'm also going to inject as if there might be a vessel there. So that involves me aspirating, compressing the vessels as I start to inject, and doing small amounts at a time, because all of these things enable nervous injectors to get the job done and lower risk for everyone. periosteum, midline, aspirate, compress vessels if they were there. .05, then stop. Come out, have a look at the aesthetic goal again, reflect. I'm going to inject from the other side because of the way the curve is sloping in, it enables my needle to go in exactly where I need it to be for this next pass. I'm going to put another new needle on though because I felt a little bit of friction there going in. Yeah, this is quite a nice angle for me. So bevel down as well because I don't want this to be coming up. I'm also once again reflecting on this shape here and choosing my position really carefully. Onto periosteum, aspirate. Got negative pressure now. I did move slightly. If I go back to where I was, I still have the power to detect a vessel if I go into it. A little bit of movement with negative pressure increases sensitivity of aspirating. Compress the artery again. Never more than 0.05. Okay, making progress. That took a decent amount of the angle off. I've only put 0.1 in total now, and it's nearly straight. So I do now need to change tack because the curve I was creating, I've shifted it now, and now there's a drop off further on. So now I need to enter slightly more superiorly, and I'm now looking at the greatest curvature. It's about 4 millimeters lower down, underneath where that little red spot is of blood. Aspirate, compress. That really brought it together. It's now 97% straight, and that last 3% makes all the difference. I'm still going to go for it. Aspirate, compress, inject. Another new needle. I'm shifting slightly further back now. Aspirate, compress, inject. I'm actually kind of 99%, maybe even 99.5. It's super straight, but there will be some swelling here, which is why I think it's worth going for 100% with just a little bit more, because once it settles, it'll probably go back to where it is now. For anyone watching this who is terrified of non-surgical rhinoplasty, it's worth really visualizing what it would take to cause blindness, because really what we'd need is for this thick product to flow all the way down a vessel that's all the way at the back of the eye. It's about 0.1 mils, all of it straight in, to cause that problem. Even if you get into a vessel, it doesn't normally flow that easily. If you block the passage of the vessel with your finger, that's going to reduce the risk. If you inject small amounts, if you aspirate first, if you've ultrasounded, all these things layer so many really significant barriers that, in my mind, it effectively goes to zero. But you have to be thinking about these things and imagining it before your animal brain will allow you to do it. You know, to override, for logic to override fear takes a lot of logic. Great, so now we're moving on to the lower face. So let's give it, men with beards, you need to give a really good clean because you just can't get to the skin as easily. Okay, so the vessel we worry about when injecting chins is the submental artery, which usually runs underneath the jawline and then curves up in front of the chin. We also have the mental artery, which is more rarely an issue because we know where it is, it comes up the foramen. But the submental is supposed to be on the lateral aspect, can be in the midline. There's sometimes even one central artery, according to some commentators I've seen. So we just want to have a quick look. It's actually very unlikely to be on the periosteum. So if you inject deep and on the midline, that's safest. But on a man, you can't inject deep on the midline because you don't want to give them a round female chin. We want angles here. So that means I need to basically either rely on the probability that the vessel will not be deep and I can inject on the periosteum and aspirate, or if you have an ultrasound, have a quick look to see if you can see where the vessel is. Okay, so whenever you're injecting chins, we need to think about all the different, it's actually a hard area, a bit like noses, because there are multiple meeting points, different planes of the face that all effectively come to an apex on the chin. And if you correct one domain without seeing what it will look like from the other side, you end up with a chin that doesn't quite fit the face. So think about the chin as a meeting point between the cheek, these facial planes here, the neck, and the frontal plane. And you really want it to project outwards in a way that looks like a continuation of those other structures. Or, in this case, we're actually trying to accommodate for the chin. I want it to be a continuation of the lateral jawline that meets an apex here, and then I'll fill in the gap in between, so that I'm making sure that all these planes fit together. As we said earlier on, a man's chin, ideal width is the width of the mouth. So the apex of his chin is obviously masculine, but it's about 5 millimeters, maybe 7 millimeters medial. So if I add just a little bit of projection here, that will create a more masculine type of beauty. I'd hesitate to use the word beauty. It's more of just looking more masculine, because not all men like to be described as beautiful. Some don't mind, but we want to go for a masculine angled jaw, okay? So similar to as we do with the cheek, you can feel for the apex so that you get an idea for the actual shape. His apex is here, and that tells me that some of my injections at least need to be lateral to that apex because I'm trying to make the chin slightly broader by half a centimeter, and the same will apply on that side. So like we always do, feel for the shape, then decide your injection point, think about the anatomy, and deliver your change in careful steps. One other thing I can see from the side is the curvature of the chin. So this is something we'll show you probably in the 3D image, which is the greatest curvature of the chin from the profile view is also a really important part of what makes for a good looking face. And the greatest curvature is usually too high. In this case, you can see projection relatively high up here, and what I'd like to do as part of the procedure is bring it lower so that it looks like a continuation of the jawline. So there will be some medial injections too that help bring the right shape. Effectively, although I can't draw because of the beard, it'll be a bolus here, one in the middle and one on the other side. I like to put pressure above it and below it to try and keep the product in the most effective place. You feeling okay?
Yeah.
Yep. Okay, now I can already sense that that's done, that's already given strength to the lower face. But now we're going to do the lateral component. So in your mind's eye, you want to line up with the oral commissure, and then, as I said right at the beginning, feel for the shape so that you know where to enter. I want to be in the lateral aspect. I'm doing a little bit of layering because getting projection is hard if you do it all on the periosteum. So I'm doing some injections, sometimes called a tower technique, where you stack them on top of each other. So I'm just aesthetically chasing a little bit more the goal that I have in my mind's eye. So we're just going over now with a little bit more in the midline. Feel for the existing shape, aesthetic goal clear in my mind, angle here, lateral part of the curvature of the mandible. Oh look, bright positive aspiration. That's pretty exciting to catch on camera. I'm going to come out, pressure on. Oh, I didn't see that on ultrasound. I might give it another scan now and see if I can see one now that I know there is something here. It looks a little bit on the darker side. So maybe it's a vein that I compressed. But this is why you layer up safety steps. So now I'm just moving off from the chin and just trying to blend in the area of the cheek with the start of the chin, so it looks like a stronger connection essentially. The key point is often just here where the medial fold would form eventually. And strengthen that. This is an area to be very careful when injecting women here because it makes them look masculine. Not a problem here, obviously. So what I'm doing now is just trying to get, similar to how I do with the rest of the face, as I'm moving across the chin, I'm looking for the catch light and trying to get an idea for the shape. I think this side has a stronger shape than that side, so I'm just going to do another little adjustment on that side to give us the angle. Okay, final adjustment. I'm just making, there's a tiny difference in curvature here. This is nice and straight. I'm going to try and project it downwards slightly. This is also very easy to do for men and tricky to do for women. Easy as in it's hard to overtreat. So I think we're done injecting. I'm just going to clean off any little remaining dots of blood. It's always good to get your patient looking as good as possible before they get the reveal. All they notice is blood spots, even if it's the world's best transformation. So there are some tiny little pinpoint entry bruises, which I can't get rid of, but they will usually disappear quite quickly. Mm-hmm. There's a little entry point on your eye, which is, it's a small bruise, but it looks a bit like the shadow, so it'll hide, to our mind's eye, it hides some of the result. It's very very mild. I think you're still going to see the result straight away. And also get all your markings off. I had a little bit of marking here from before. Make sure you haven't left drawings on your patient. Okay, just want to have a look, see what you think. Yeah. Now you are currently, I've made a mistake, which is I've let the patient look in the worst light possible, directly from above. Because you're getting shadows. So we'll show you again in a different light as well. But
pretty good.
Yeah.
Yeah, really, really good. Refreshed.
Yeah.
Yeah, the chin is different, isn't it? Wow. Yeah, awesome.
And nose as well. If you probably only see it from the side, but it's just basically straight.
Yeah.
Yeah.
Amazing. Yeah, it's really good work. Thanks.
Great. Thank you.
Just look a lot younger. Really
Yeah.
nice life.
So, yeah, I made a mistake with the light, but we'll get you have a look there.
Yeah.
As long as you tilt your head back, that light is the one that's casting shadows.
My face still feels a bit numb to talk.
Right.
Yeah, wow. Yeah, I really like that.
Great. Guys, thank you very much for joining. This is our first one, so it'd be great to have some feedback and questions. And I didn't watch all of that because I was actually working and then came straight here. I remember doing it, but I didn't watch the whole thing until the end. We have a spotlight directly above the patient. It's the worst thing. So I didn't actually look as bad as I thought, but in your clinics, you want nice light when you reveal things. And I always know that because if they get a negative experience the moment when they first look, it can distort everything afterwards. So it's a really important moment to make it look as good as possible, which is why I was faffing about pointing at the spotlight in the ceiling. So we now have in our process that the spotlight goes off and we leave the other lights on, because otherwise it's straight from above. But I hope you've learned something from that. Let me hear what you think. I'll pick on the people who've got their cameras on. Sander, I'm actually working. Do you mind taking kids home? Do me a favor. I need your help to get Albie outside and quiet, because I'm working. There's literally people watching me now. Okay. Bye, Albie.
There's lots of quick questions in the chat though.
Okay. Right. Let's.
Tim, I've got a quick before and after shot. If you want me to share the screen.
Okay. Yeah, that'd be good.
Yeah. Well.
I haven't actually seen that myself yet. Okay, cool.
Can you see that there?
Yeah. Can I make it bigger and me smaller?
Make it bigger. Let's see. Doesn't. It's not really liking it to make it bigger, to be honest.
Okay. How do I make myself smaller? There we go. Okay.
Right, let me download it, and then everyone can see it a bit better. Then I'll do that.
So I don't know. I can't see the questions because I've joined on a different thing. So whoever's right. I don't know if you can in the chat.
I can read them out for you if you want.
Okay.
If that's helpful.
I can see one from Diana saying, I have a question about the chin. Did the patient have a lower jaw retrusion class 2 bite? Sorry, I can't read this. If yes, will this volumization of the chin make retrusive lips and a deep mental crease? So first thing is the bite, I didn't look at his teeth. I can't remember, unfortunately. Will the volumization make for retrusive lips? This does happen if you've got a very small lip. What you mean is that as you replace volume, a lip that's kind of like this, you pull it in and it can actually make the lip look too small. So you end up with something like this. I don't know how well you can see, but essentially it rotates the lip inwards. So it's worth thinking about. Is way less important on men. Obviously in women, they notice it because lips are such a key thing. And if you're going to treat someone's chin, you should know about that. As for the crease, if you will be volumized chin, so a deep mental crease would not happen because usually I treat the chin and the mental crease together. Particularly on a female now, because it's part of the restoration. Now, he had a beard that was making it a bit harder to think just about the contours of the skin. So I was thinking more about the overall size and positioning of his chin. But I don't think, you can see he certainly doesn't have more of a mental crease. Maybe it's rotated his lip slightly, but I don't think I would normally try and treat that anyway on a man.
Nice difference.
I may if it looked small. So it looks like I'm saying that myself, great result. I think that's Miranda saying great result in the comments on my account.
There was an initial question at the beginning, Tim, from Alicia just asking what product was being used.
So mostly I use Juvenile Bicross products. That's not because I think they're necessarily the best, but I've used them for many years and I've tested them and I've audited them, and I'm very confident that they give the results that I expect. It's more, I would say, so in terms of, just to cut to the chase, it's mostly Voluma. I would actually prefer to have used a stiffer product in his chin, but we just didn't have any on that. And I had used Voluma for years in chins, but there's Volux, which is slightly better at emulating bone. And that's really the way I think about products is, are you emulating fat, a deep fat pad, which is something like Voluma, or are you emulating bone, which is Bicross, Volux. But Voluma is not that different. I mean, they're very proud of Volux, but I can't be 100% sure I can tell the difference on most days. They look pretty similar at the end. But you do need a stiffer product for chins. I don't think I used any Vola. For tear trough, it would be something I used Volbella, but something like Teoxane's Redensity 2 would be the second choice if I was to use a different brand. And I prefer just using FDA-approved products, even though we're in the UK and we have no rules. I like things that have been tested on humans. There's some human data. You just know a bit more about them.
And Claire was asking if you could advise what the clip is that you're using on your thumb.
Okay, yeah. So that you'll hear more about it. I really did like that. I've had the it's called K-Ring Designs, and what I'll try and do is see if they'll make an offer to our membership. That's one of the things I want to do with the membership is get companies to make things better for us. So by pitching them. So they seem like nice people. They sent me one for free. I was actually trying to buy it, and then my card failed, and they saw my name, and they're like, they just sent it anyway. Obviously, they're not super expensive, but it was cool, and I do think it's better than the other lady. I really like her as a person, but her silver ring was faffy. Like I had tried to use it, but it kind of comes off, doesn't feel like comfortable. So I really like the K-Ring Designs. That's who it is, K-Ring Designs. If you tell them I sent you, he'll also be super happy if you decide to buy some. But I'm going to ask them if they would make an offer to our members.
We also had a question from Alicia. She would be interested to know how you do a tip, specifically how you would approach the supratip lobule. Would you ever enter via the middle crus or go from the top?
So I usually go from the top. I try my best not to inject tips. So, and that's not because you can't inject tips, but it's usually the last thing that I do. And if I'm going to do them, I've done both, but I usually enter from the top, slide the needle in, do a depth check to see how much room there is. So I'm kind of elevating to see if it's mobile, and then inject very slowly, looking that there isn't any blanching while I'm injecting, which is usually, it's the pressure in the tip that's an issue. So the short answer is I might do both. I don't think there's anything wrong with entering at different angles, but I prefer entering from the top, and I also try not to inject the tip too much because I've just seen so many red tips coming back through the clinic. You never see them, unfortunately, on Instagram. You just see the wow results. But then those same patients, it's one of the most common patient complaints I get is my nose is red 6 weeks after. And it's kind of annoying. So that's why I don't like injecting tips too much.
Jeanette, you had a question about the flash aspiration. Do you want to ask Tim?
Yeah. So Tim, when we were looking through the video, and I don't know whether you caught that bit this evening, you drew back, you got a flashback, and you withdrew immediately, and then you got your ultrasound out, and you did your scan. We didn't see what the scan result was, so we assumed it was a vein, not an artery, because you then went back in. But when you aspirated, there was quite a flashback in the syringe. But when we went back on camera, there didn't appear to be any blood in the syringe. So I wondered, had you wasted that syringe, or was it just like, it just didn't show up after?
Yeah, no, so I definitely wouldn't have wasted it. All I do is take off the syringe, the needle that goes in the bin.
Yeah.
And then I stand over the sink and I squeeze out the filler until it goes away from pink to white.
Right. Okay. Yes. So a tiny little bit.
Yeah, and then I either give it a little shake or scrape it off with the new needle and put it on. And the downside, if you can't get it to come off, and you try not to waste too much product, especially if you're in the US, it's so expensive. So you put it back on, but then you often get a tiny red dot that's kind of a relic of it. You just need to mentally note that, otherwise unfortunately you think you're getting positives all the time after that. Like your brain goes, oh no, it's another positive, and it's actually just the old.
A little bit darker.
Yeah. But yeah, you don't need to discard it. The only time you need to discard it is when, and this has happened only a handful of times to me, it's such a big aspiration that it sucks blood all the way up the side and it mixes with all your product. And then you're just injecting inflammatory blood into everyone. And so I usually bin those.
Okay, so get rid of as much as you can if you can.
Yeah.
Okay, thank you.
And I think Claire also mirrored what you just said, Jeanette, about it be interesting if we could see what you found with the ultrasound.
Oh, yeah, there was nothing on the ultrasound. That's why I didn't share it. I couldn't see it. So I think it was either a vein that was compressed, or maybe I wasn't angling the ultrasound in the right direction, but I couldn't find anything clearly on that. Sometimes it's really exciting because you scan it and you're like, wow, there's a great artery, and I found it with my aspiration, but not this time. I couldn't find it.
Diana had a question about the chin. Did the patient have lower jaw protrusion? I think you've already answered that one. Happy Tim would see that one. Okay. Has anybody else got any questions that they've not put in the chat? Yeah,
I did put one in the chat, but I think actually it went to Tim directly, so I made a mistake. I didn't know how to correct it. But the question was, how many mils was actually in the chin in total? I couldn't, with the break in the clip, I didn't know whether it was 3 or 4, which seems a huge amount to me. But it obviously had a great effect. But
yeah, so for an augmentation, if you actually want a chin to look bigger in a man, then like 2 is your minimum, really. So I actually can't remember off the top of my head. It was 3 or 4. But yeah, 4 is not hard to use for. But I would say for it's much harder with a man. If you're treating a female who just wants her chin slightly lowered or slightly more pronounced, then often 1 mil or even half a mil, you can get some improvement. In fact, we've got one coming up, one of our staff members, but that was more than 1 mil. So I think that's one thing, particularly the Americans might notice. I think we use more volumes because we're a little bit less limited with price. I know you guys pay a fortune for a mil, but I still think seeing it is useful because patients actually do want the result. They just, they need someone with conviction to say that it's worth that amount. And a percentage of people will obviously have a bigger treatment. You just have to consult them well and believe in what you're recommending, which applies to Brits in the same way. Let me share one other pearl, if I call it a pearl myself. I was stuck at low volume treatments for years because of cost and my own barrier to price. So I wouldn't quote people for everything I knew I could do because I thought they would reject me. And so I would just try and keep it around 4 or 5 mils, like 4 mils even for years. Then I did a full face treatment on someone, and I told myself, I'm just going to pay for this, and I just want to get the best result I possibly can, just like you just saw me inject, just chasing the result. And I think I used 18 mils eventually. And she is still friends with me on Facebook, and I keep an eye on her face that way. And it hasn't run out. It's been 5 or 6 years, and she still has, I'd say, 80% of the benefit. She doesn't look over-treated. But what it did for me is it blew up my own barriers. Like now I know that sometimes people just need more mils, and if you could say that with conviction, 30% of people don't care about the price. The other 30% need more conversation, but a lot of people just say, do the best that you can. And you will be surprised when you get it out of your own way, how much people are happy to pay when they believe that you can deliver a result.
Could I ask another little question on top of that? So I had 0.2, maybe 0.4 at most in my chin, and I found it quite uncomfortable. So the size of that amount of volume, would you ever get any feedback of how uncomfortable it is for the patient in the days?
So I know it aches. The best thing is to ask a patient. I don't know if Miranda's still around. She's had her chin treated.
Yeah.
What was it like?
No problems in the chin. I'm a big chin fan. It always really helps me. And I once had 16 mils in a couple, took a few hours, and I was basically fine. I think some of it's luck, but I guess it depends on the injector as well. But yeah, no.
Or if you get a bruise, then it hurts. Even a small injection might hurt for much longer. Miranda's hard to explain, by the way. The 16 mil thing is she had lost loads of volume laterally and become much squarer. So most of the work actually is happening, temples, cheek, and this preauricular area, and then chin and jawline. And then also the other interesting thing about Miranda, because she's long and slim is it's getting her cheeks to project this way, so you don't actually see it very often, but she becomes a little bit flat, and that's one of the most volume, takes a lot of volume because there's little support underneath the cheek. So that was the start. You've never had anywhere near that much on subsequent treatments, so it's not an every time thing, which also something.
I look supernatural, so
yeah.
I look supernatural, so there's no problem.
It's a shocking number for a lot of people, though. So I just want to add a little bit of detail. Okay. So I did saw some other pictures come through. So Andrew asks, why did you treat the chin? Did the patient specifically ask? If not, why did you feel he needed it? Yes, the patient specifically asked, and he also, I think he needs it. I think you can see it before and after that he basically has what you get with some chins is they kind of pull up and they go with a slight negative expression. And so when you pull the chin back down, firstly, it's beautifying for men. They tend to look better looking. You can see now in this picture, this shape, the relatively sad shape, comes partly from a strong upward pull of the chin next to a medial cheek fat pad, because that medial cheek fat pad is also creating a more sad aura and a slightly weaker aura, because what you see on the left, if I was to caricature it, is more of a grumpy baby face, and on the right, he just looks more like a man. It's just a stronger, there's more integrity, there's less, the jawline is one straight line versus this interruption here with the cheek fat pad. So I may have recommended that even if he hadn't mentioned it, but he also did specifically mention it. I don't know if you saw the consultation, it's probably too long to show you all of it, but he's also an injector, so he knew a fair amount about stuff that he wanted and why.
And don't forget, guys, we are going to share the consultations for Technique Tuesday. We're going to share them in the consultation training, the proper consultation training. So it's going to be great to be able to see what he did and then afterwards see the consultations.
So we did 4 mils in his chin apparently. And then Chloe, who's just had her chin treated, who's another member of staff, so she had 3 days of aching. Alicia asked, what ultrasound did I use? It is a Clarius, the only Clarius, but I forgot the name of it, but it's a Clarius. But it's the cheapest Clarius to get started with. I think it was about £7,000 in the UK. It might be slightly cheaper now, as there's a bit of competition happening, but that's the cheapest entry into a facial ultrasound with a decent resolution. By the way, you'll see me inject the next patient. The one I did today, I didn't use the ultrasound at all. It's fun using an ultrasound, and it's useful if you get a positive, but I don't want you all to believe that you have to do all your injections under ultrasound. I've injected 16, 17 years without an ultrasound and had one minor vascular occlusion on a lip. And I would have found it helpful to manage various cases that were non-emergency stuff. I used it once in an emergency and it was kind of helpful, but not the be all and end all. So I'm not convinced that it's a baseline. I think when you're ready, get one. When you've got a bit of cash and you're not starting out, fine. When you've got a big thriving clinic, get one. But I wouldn't start out, before you've got a steady stream of patients dropping $7,000 on one, unless you want to focus on like one particular area to become an expert on. Like if you want to do noses and you won't do them unless you have an ultrasound, then you should get an ultrasound a bit sooner. I hope that helps. Okay. Any other questions, comments? Or you can shout criticisms, abuse. I'm up for everything today. I've had a good day, so I can take it. I wish I'd watched more of it before coming on, because I need to watch the edit to see how well it was edited. But presumably, if you're still here, it wasn't. It was quite fun watching it.
Do you want to mention that we're cutting them, making them shorter as of next week? Because this one was quite long.
Yeah, well, what do you guys think about that? That might be a good question. Maybe not. We need to ask everyone. I think it's quite a long thing to watch, so we might just make shorter versions of them. Eventually, it'll all be searchable on an online. This is Alicia's idea, to have an injection library. So as we're collecting them, we'll make them searchable with keywords. So if you want to look at a chin treatment, you'll get all the chin ones up. Concertina lines, whatever we label them as, you'll have them all. But it might be better from a learning perspective to do shorter things that you don't have to give up, whole evenings for, but more kind of 45 minutes at maximum, including a Q&A, maybe 20-minute procedures. What do you guys think?
Yeah, I would be keen to hear your thoughts on that, guys, as
I think we should.
it'll determine what we do next week.
We'll need to survey officially.
Can I ask another question?
It's interesting, some people are saying non-edited. Maybe we could just put the non-edited up version somewhere else. I don't think most people will sit through the whole non-edited, but if you want to see, that wouldn't be any skin off our nose to put the whole video up separately. It's long though, like 2.5 hours, something like that. And there's a bit of chatting. We'll have to check what else we say on camera, because we do have a sense of humor that not everyone would enjoy. So we'll see.
Can I ask another question?
Yes,
Yeah,
sure.
If we looked at the pictures of the before and after, it was quite noticeable that the shape of his mouth changed. The side of his mouth went up. He lost that concave appearance. Was that what caused that? Was that the treatment of the chin, or was it because you treated his cheeks, which pulled it up?
I don't think
His
it's.
mouth is.
Yeah. I can see this difference. It's interesting. I think a lot of it is around. There's an idea that as the muscles in the lower face basically are less resisted by fat pads, if you have tone in your mentalis, it also goes with an increased tone in your DAO. So if you do the opposite and you pull the muscles straighter, it relaxes the DAO. That's one theory I've heard. I think the cheeks would help, because if there's ever going to be but it's very subtle. I don't really think you're lifting with a cheek treatment. It's this kind of cheek treatment anyway. It's a bit too high up, but I think it'll be more to do with the chin, pulling the mentalis straight and then relaxing the DAO. This is the myomodulation theory, as it's called. A lot of people don't like the theory, but I didn't choose these pictures. Chloe went through them, picked them, and this is what we got. So, and this is what he looked like on the day. So I think it's myomodulation, if you believe in that.
Can I just add to that, which is that whenever I have my chin done, my lips always seem less full. Is that the same thing, Tim?
Yeah, so I think that's what one of the questions referred to, is that the same thing that you can actually see a bit of it on him. If you look at his lower lip in the before picture, it looks slightly protruded out, like that. You can see me. So it's the same thing. Your mentalis is pulling up. The mentalis then basically puts the pressure on the lip to kind of rotate outwards. And in most people, that just makes you look less grumpy. But if you've got a good lower lip and you treat it and you don't accommodate for that, you end up with a female who looks slightly strict, might be the term. They look more serious and cold. And it's important for females, whereas men, you can understand that actually just makes you look, it's a different form of strength. They don't actually necessarily look less attractive with a slightly smaller lip.
It's fascinating. We should do some content on that. That's a great observation.
Yeah. Yeah, worth noticing. And now that you've all seen it, you'll remember, and your patient is often... it works way better if you say before you've done the treatment than if you say after. So you'd say, if I'm going to treat your chin, your lip might look smaller, so you might want to budget for a little bit of lip volume too. That's fine. If it's like they notice 3 weeks later, then they will say it's your fault. So it's a great learning point that you guys have picked that up. By the way, that's super rare that people come back complaining about a small lip. The first time I saw it was a patient after the before and after was published. I saw it on the before and after, the patient didn't. And that was my learning. Alicia asks, where did I place the tear trough treatment? So the tear trough is super narrow area and there's not a lot of tissue, but the biggest problem with tear troughs is that they become puffy afterwards. And I've dabbled with cannula and needle over the years. I love using cannula because it's so easy to just slide in. You put your product in, it looks great, and there's no bruising, and it's quick and easy. But unfortunately, I'm convinced, although I've never got solid data, I just haven't got around to auditing it. I'm convinced that they end up with reversals 6 months, 12 months later, more often than the needle ones. Needle on periosteum, smaller amounts on the bone. It's hidden underneath all the fat. And I think it's better long term, even though it's harder on the day. So that's why I have ping ponged, and I've had doctors I've trusted and worked with for years do exactly the same. We start with needle, then we go cannula, everyone's happy. Then we get all reversals and we swing back to using a needle. The rule of thumb, obviously, with all tear troughs is to try and put as little in as possible, so that you don't have to, even no matter what instrument you decide to use, you're putting in as small amounts as possible. So it's on periosteum, by the way, just to be black and white, Alicia. So is it, unless you guys are going to ask me more questions, anyone here who's particularly have your camera on, is there anything that you've picked up that you can see or that you want to try or do next time you do a treatment? I'd like to hear, how is this going to become practical to you? And if there's anything we can do to help make that real. In particular, that would be something like a commitment to do a treatment. Say presumably you've done practical training, but to upgrade it, you need more confidence often to recommend it to a patient. So it'd be great to hear that, in your next consultation, you're going to talk about chins and you're going to be more comfortable with 2 mils instead of 0.5 mil or something like that. That's the kind of difference I'd like to see. If there's anything like that. What about you, Jeanette? You're nodding, so what do you think?
I'd be a little bit more daring with a male chin, obviously, than a female chin.
Great point. So you should, it's easy to wreck a female chin, and it's really hard to do the same with a male, because chins are like female cheeks. In a man, a big chin you get more attractive. Whereas with females, you tilt over a little bit and they suddenly become masculinized. So that is the right attitude.
Mm-hmm. Thank you.
What about you, Andrew? Is anything that you're going to take from this for your next clinic, or at least has been an important learning point?
Well, I have to be honest, I've not actually treated any men yet, but I mean, it's given me a good idea of the difference between treating men and women.
Great.
One of the cheeks as well.
Great. I hope, I don't know how much you was, because I haven't managed to watch the whole thing, but did I talk about how I described male beauty? Did you see any of that? Because men balk when you say the word beauty, because, I can say this to you, we're fellow men, we're tough guys, we're warriors. We're not interested in being beautiful. We want to look strong. So it becomes much more about angles, integrity, projection, things that represent strength. Men quite like hearing those things, but anything that's too gentle, it causes discomfort at least in a straight male. It can be different. Other people have different values, different goals, but it's useful to know that, because I had so many awkward conversations where I was using the more female terminology, and it's useful to understand. Also, the concept is different. It's angles, shapes, projection, not volume and curves. And good to see the before and after. I haven't seen it. They just need to be lined up slightly, so that they're the same height. That'll make it easier.
I think it's fascinating, the cheek, what's happened there. It's just so much smoother.
Yeah, so there's another learning point to use in your clinics is the reflections. If you have decent bright lights, you can use the way that the catch light is to blend things in. So you can see his cheek was kind of isolated, and then I basically put filler above it, lateral, I think, and medial to it, and then blended that all in. So it actually weirdly looks slightly smaller. Even though it's technically will be bigger, but that's just by looking at those reflections and simplifying it.
This is going to sound a bit harsh, but he's much more attractive on the right, isn't it? Even his beard looks great. He looks thinner, younger, and more sculpted.
Yeah, I think the chin's the most powerful thing.
I think the chin looks amazing. It's definitely, it's made him look more pronounced and took away the bit of extra that he's got underneath his chin, as to be polite.
Absolutely.
I think the nose also probably adds a little bit of strength, just that it's straighter, simpler. It's funny, you could... Sorry?
Sorry, no, I was going to say what you said about cheeks as well, that with the female cheeks, they like to have a higher cheek, whereas men, it's more anterior that's important, right. Not to go high and wide.
So I was thinking about this when Johnny Depp was in his trial. Like if you look at him when he's young, he's got these anterior projections, and you know, obviously he's good looking, but it's a good thing to think about, that anterior rather than lateral. And look at most men; they don't have any transition down here. It's almost completely straight. A lot of new injectors do female style treatments, and they end up looking feminized. So it's great that you can experience that in this case. And the other thing when you treat a man is they really value hearing this difference, because through talking to hundreds of men, a lot of their fears are centered around exactly that, like, will I look female, overtreated, pillow, all those things. Their idea of of overtreated men is actually feminized and overtreated. So when they hear you talking about the masculine outcome, it's very reassuring. It's a great thing to weave into any consultations.
Right, let's get these kids to bed.
Okay, so yeah, guys, any further thoughts or feedback? Because that's our first one. I'd like to hear how you think we can improve it. You can drop us, and we'll probably survey you at some point. But also, especially if you use anything that you've learned today, I'd love to hear that as well. So if you find it useful and you actually implement it, then share that on the group, because that's the most solid feedback loop we can get. And you know, I hope that was helpful. So thank you, and thanks very much for coming tonight.
Thank you. I found it mesmerizing.
Oh, great. Good night, everyone. Thank you, Jeanette and Claire and Kat. Thank you.
Thanks,
Good
guys.
night, all. Bye-bye.
Bye.